Welcome back to the program. This is Good Morning Kenya. My name is Vivian Degwa, and we are done with the political segment. Right now, we get into a matter that is just as important, and that is the Social Health Authority. Now, we know that we are transitioning from NHIF to SHA, and we just want to know how that transition is supposed to happen and how smoothly they will ensure, or rather the Ministry of Health will ensure that it gets to happen. And all the questions that you may be having concerning that shift, we'll be asking all about that here today. And joining me for that conversation is Dr. Elizabeth Wangia. Dr. Elizabeth is the head of financing, Ministry of Health. Just the right person for this conversation. Good morning, ma'am.
Good morning to you, Vivian.
You're well?
I'm very well. Okay,
we're pleased to have you here. We have so many questions for you because we need to understand that transition from NHIF to SHA, SHIF, and all that. So if we may just begin by you telling us what the Social Health Authority is.
So thank you so much, Vivian, for giving me this opportunity to share with you and, of course, with all Kenyans matters regarding social health insurance. So just to start with, social health insurance is a concept to start with where people really put their funds together, people pull their resources together. It's usually government supported. You pull your resources so that you're able to cover more people. So as a country, we have subscribed to some of our global agenda, like this Sustainable Development Goals, where universal health coverage is one of the goals we need to achieve by 2030. And universal health coverage basically talks about citizens or people being able to access quality services at a price that is affordable, not free. A price that is affordable to them and that won't push them into poverty. So when we look at social insurance, the purpose of social insurance is actually that, to pull all these resources together to ensure that even those vulnerable people who are not able to pay are catered for by the rest of the population. So it's based on that the Social Health Authority was established. And the Social Health Authority is the predecessor of the National Health Insurance Fund, which was established over 60 years ago. Of course, it had grown in its mandate and its scope over time. But given that this time we were shifting to really focusing on the entire population, that's the change to the Social Health Authority.
All right. So as you've mentioned, NHIF has been here for the past 60 years. That's what we've been having as an health insurance fund. So what's the difference, what's the difference with NHIF and SHA, and just where is the need, and what is the need of us having SHA and not maybe trying to look at NHIF and tweak some things?
Okay. So NHIF when it started in the 60s, it mainly targeted the employed, the formal sector, and it was giving them a basic cover. Over time, it expanded its scope to cover even people within the informal sector, those who were willing, and it was more or less voluntary. And with that also, the scope expanded. If you remember, previously, it used to be only bed charge. You could just hear of bed charge. But then over time, the scope expanded. We started seeing payment for even surgical services, payment for cancer management, payment for dialysis, and the like. As part of the expansion, they also included what you call enhanced schemes. So the enhanced schemes catered for special groups, mainly government, and one of them is like the civil servant scheme, which all civil servants used to enjoy. Counties also used to, negotiate with the NHIF and, have also some enhancement of their schemes, some parastatals and the like. But over time, it was clear that these schemes were quite unsustainable. NHIF had close to 98 schemes. So that is one thing. So most of these schemes, you'd find they are enhanced. They are more or less like a private insurer. in fact, much better. In fact, if you talk to civil servants, what they were entitled to was way better than what they would have ever got in any private insurance. But it was at the expense of their contribution, because if you look at what was even contributed for that scheme, it was way less than what the scheme actually costed. And therefore, over time, based on even data and all that, it was seen that some of these schemes were actually unsustainable. So with that, social health insurance, number one thing, doesn't have enhanced schemes. So it is a purely social health insurance. And number two, there were quite a number of functions that were performed by NHIF that were more or less conflicting with, with each other. So they were more or less like you are the judge, you are the jury, you are the prosecutor. So you are the one who is bringing people on board, you are the one who is, purchasing the services. And if there are any disputes, you are the same one who has to address these disputes. So as we moved from NHIF to Social Health Authority, some of these functions have actually been split. That is one game changer. When it comes to how do you bring facilities on board, that has been taken away from Social Health Authority. That one will be done by this with the specific regulator. If there are health facilities like hospitals, clinics, that function will be taken up by Kenya Medical Practitioners and Dentist Council. As we progress, we'll be bringing on board even private pharmacies, and therefore the regulator will be the Pharmacy and Poisons Board. If we go into contracting laboratories standalone, then the regulator will be Kenya Medical Laboratory and Technicians Board. So the regulators will be the ones to tell us these are our facilities and this is their capacity, and not the institution itself going to check on the facility and deciding. Because if I'm the one buying the services, I can as well go to a facility and probably say that this is I would say a level 5 facility when it's a level 4 facility. And that's where a lot of issues around even fraud come in. So that is one game changer. The other game changer is around who develops these benefits. When you hear that we have benefits, and the benefits are around, because the benefits answer the question, what is in it when I have my card? Will I get maternity services? Will I get renal services and the like? So even that determining of the benefit is done independently by a benefit. It will be done by a benefit package experts panel. And it's because we want to really use a lot of data. We want to use a lot of data. We want to engage the universities who will come on board, do the research and tell us for sure this intervention, if you go this way, you won't get value for your money, because it's not a matter of someone just saying, can it cover this, can it cover that? No, we need to be informed by data. Then the third thing is around the dispute resolution. With Social Health Authority, we have the Dispute Resolution Tribunal. Therefore, if any stakeholder, whether it's a Kenyan, normal Kenyan, or a facility, have any disputes regarding the authority, they will present this to the Dispute Resolution Tribunal, which is an independent entity, and therefore that independence in terms of determination of whatever case.
Okay, so those are the differences.
Those are the main differences.
Main differences that we have. So are we completely doing away with NHIF? And if that is the case, what happens to the contribution that people were making? You know, if I've been contributing for NHIF rather for say 20 years, you know, what happens now to my contributions? Are we transitioning with the money, or how are we doing it?
Yeah, so the final thing I'd forgotten to mention about one of the key differences is digitization. SHA will be fully digitized or largely digitized, therefore also limiting the human interface. So on your question around, so what happens to the contributions? First, NHIF is a form of an insurance. Just like your motor vehicle insurance, when the year or the period comes to an end, it's not a cumulative contribution like probably NSSF. And therefore, you can only talk about your contribution based on the overpayments, because there are some people actually who overpaid, probably paid for 2 years in advance. And therefore, those are the ones, for those people who paid in advance, their contributions will be rolled over to SHA. Now, if you are in the informal sector, what will be done is a means testing. And earlier, there were the discussions around the means testing in the education sector. Also within the health sector, there will be the means testing. So if you do the means testing, and your income is, and your contributions, your premiums are found to be a certain amount. Let me just say, I give an example, probably 10,000. And you had paid in advance, say for 1 year, under NHIF, which is 6,000, then you will only need to top up for the 4,000. Because also in the informal sector, the contributions are annual. So basically there is no contribution that will be lost. All contributions will be, if for any contribution you have done in advance, it will be rolled over, and based on your current year's contribution under SHA, it will be subtracted from that what was paid in advance. So there'll be no loss when it comes to the resources. The other question you asked is NHIF done? Once the Social Health Insurance Act was passed, the National Health Insurance Fund Act was rendered redundant. And by then, if you look at the act, it says that from the appointed date, NHIF had 1 year to wind down. And this was 22nd of November. So as we proceed, we have up to 21st of November to fully say that now we have transited from NHIF to SHA. Otherwise, in terms of service delivery, even you have had His Excellency the President declaring that from 1st October, we'll start offering services under SHA. But that doesn't mean that NHIF has fully wound up. Wound down, because there are other things that still need to, other processes, even transfer of assets and all that need to be done for you to completely say that you have wounded down. Yes.
All right, I hear you on that. Now, is there specific eligibility criteria to SHA? Because with NHIF, it was available for everyone. The employed, the non-employed, it was available to everyone. So is there a specific eligibility? And we'll come back to answer that. We take a break, and then when we come back, you answer me that. All right, let's take a break. We'll be back in a moment.
SHA is a social health insurance. It's limited actually to the citizens. So number one, so long as you're a citizen of Kenya, you are eligible to join the social health insurance. Number two, the refugees, the ones who have documented refugees, are also eligible. And also the residents. So you may not be a Kenyan, but you are a resident. You are captured as a resident and by immigration. Then those are also considered eligible. The other thing is also for the prisoners. We count also the prisoners. They need to be members of the social health insurance. Yeah. So basically, the eligibility is you have to be a Kenyan, or a resident, or a refugee.
All right, so you need to be a citizen of the country, a resident in the country, or a refugee in Kenya. Okay, there's a question that has just come in, and someone is asking, why are we needed to register afresh? You already have our data for those who are already on the NHIF platform, so why do they need to register afresh when you can just take that data and move forward with it?
Yeah, so actually that's, as I said, SHA will be digitized. Fully, I would say, largely digitized. And therefore, we really are embracing, the use of other systems to feed into our system. So first, for all new new members and old members, all of their data is pulled from the National Registration Bureau. So that is your your registration, including your biometrics. So this time there'll be no need to go and do your biometrics unless you're going to seek services. So both your details plus your biometrics will be captured. For the members who are already in the database, their information will be transferred. But then in case you need maybe to update your biometrics, maybe not biometrics, if you need to update your dependents, probably you have got a new spouse, or your spouse passed on, or you have separated, or you have new additional children, then you actually go and update, and you really need to also attach the required documents. For instance, the birth certificate. If it's a child, you have to attach the birth certificate just as proof that this is your child. Many members of NHIF you'd find will be registered as members, but they have not added their dependents. They have not declared, especially maybe someone is just working. I would give an example, and their spouse maybe is in the rural area. Probably they have not even captured their spouse, and we have seen such situations where someone falls sick, maybe in the rural area, they go to a facility, they're told to pay, and it's only upon interrogating them and ask them, what does your spouse do? Then they realize their spouse is actually employed. Then on checking their ID, they realize they're actually a dependent. So this person would have paid cash. Even the member themselves didn't think about, the NHIF deduction as a benefit to them. But then you realize a lot of people actually added their dependents upon admission. So we are saying even for now, it will be good, even if the data will be transferred, to confirm your dependents and update if necessary, if any.
Okay.
Yes.
All right. There's also another question that came in, and that was on the deductions. Why is it more expensive now? Why is SHA deducting more?
Yeah, so this is usually more or less a misconception that SHA is deducting more. Actually, what's happening is that the contributions are now more equitable. Previously, when you'd find when there was a fixed rate of 500, and probably someone's salary is way less than even 10,000, they would still pay the 500, either salary or even their general income, say in the informal sector, and that translates to close to 5% of whatever their income is. And these are the majority of Kenyans, by the way. The majority of Kenyans are those ones who are either in the informal sector and were still paying the constant 500, or even the employed up to, for people earning up to 40,000, who are close to 60% of the population actually. Most of these people were actually paying more than 2.75%. Now, this figure started narrowing down as you earned more. And therefore, that's the question around equity. Was that equitable? Who was crying on behalf of these people who were earning less than 40,000 and were already paying more than 2.75? It's because they are not here on the table. They don't appear on the table in the boardrooms to defend themselves. So for us, looking at it, we say these contributions have to be equitable, and therefore they need to have that fixed percentage of 2.75. So whether you're earning 10,000 or you're earning 1 million, it is the same 2.75. It's proportionate to what you're earning, and therefore, in absolute figures, it may look higher, but proportionately, these people who have been earning less than 40,000 have constantly, over the many years, been paying 2.75 and above, but no one used to talk about it. It's until it started getting into the bracket of the higher earning people that and these are the people who sit in the boardrooms. They are the ones who can be invited here, like me, to speak. Yeah. And therefore, that's why now there is an outcry. But before, there was no outcry when this was already happening. So we are saying for now we have equalized everyone, and we are saying everyone should be at 2.75.
Okay, yeah. I get you on the equity. Now, after the registration, you know, on the *147 hash, when one is done with the registration, they're asked to go to the offices. Where are the SHA offices? We know the NHIF offices. We have no idea on where the SHA offices are.
Yeah, that's a good question, because the law is very clear that on the appointed date, the one I talked about, 22nd of November 2023, all assets and liabilities that were for NHIF become those of SHA. Of course, the administrative processes follow in terms of transfers and the like, and therefore even all those NHIF branches which were part of the assets of NHIF become automatically you know, the property of SHA. So when we talk about SHA branches, they're just the NHIF, former NHIF branches.
Okay.
And just a correction on that, this registration is actually, you can actually do the full registration in one sitting. So you could either do *147, with *147 you may not be able to upload, say if you need to add dependents, you may not be able to upload say a birth certificate and the like. But then there is the website, there is the online version. If you go to www.sha.go.ke, you will be able to complete that process to the end. You don't need to go to a SHA office.
Okay.
Yes. So as I indicated, the biometrics data will also be fully transferred. So once, actually I could have shown you my SHA card or number. Once you register, when you finish your registration on sha.go.ke, you get a SHA number. And with that SHA number, you should be able to seek services immediately. With NHIF, you needed to wait for 90 days before you're able to seek services. But with SHA, once you have registered and you have a SHA number, you should be able to walk to the nearest facility the following day or immediately. If it's a primary level facility, dispensary or a health center, those are the primary level facilities, you'll be able to get a service immediately. For the secondary level facilities, the hospitals, the former, you know, the current sub-county hospitals, county hospitals, and the referral hospitals, you need to be a paid-up member. So for you to access services at that level of care, you need to have prove that you have fully paid up. If you are in the informal sector, the payment has to be an annual premium. If it's the formal sector, then you need to, they'll just be proof that your employer has been remitting your contributions. So that's one plus that is there with SHA, that there is no waiting time. And that services at primary level, dispensaries and health centers will actually be free of charge to the citizen. They are not free. Someone is paying. It's because the government has put in resources towards that. So it's publicly financed, but to the citizens, they'll receive services at no cost.
Okay. Now, as we come to a close of this conversation, that I feel we should be having more of this, you know, so that people, or rather just we, would be able to get to understand this shift better. My question is on the healthcare services. Will we be able to see a change in healthcare services, positive change in healthcare services, and how will we see these changes?
Yes, so, you know, SHA will contract all facilities, and when I say all, I mean the public facilities, the private facilities, and even the faith-based facilities. And therefore, even at facility level, they have the sole responsibility. Once you sign that contract, because there is a contract saying that at primary level, you should be able to offer these services, consultation, lab, medicines, and all that. If it's an inpatient, you need to maybe bed charges, nursing charges, and all that. So when you sign that contract, it binds you. It's a contract between you and the authority, a facility and the authority. And that contract should be binding in the sense that if you signed it, you should offer that service. We know that may not necessarily happen, but we know that since no one is being locked to a facility, people will vote with their feet. So if it will be well known, it's usually well known in a community that if you go to that facility, you don't get maybe medicines. If you go to this facility, you'll get. So people will vote with their feet and go to the facility where these services will be offered. And the ripple effect is that this other facility that was not offering services will not get the clients, and therefore they have to do their investments. And we have seen several facilities, even in the government sector, that have really upped their game to the extent that they are competing with even the private facilities. And even if you go mashinani, most people have the faith and trust actually in public facilities. So it may not happen as a bang, but progressively, as they also get their reimbursements, then the services also will improve. But they have the sole responsibility, the facility has the sole responsibility to also invest so that they abide to the contract they signed with SHA to offer quality services at the price that has been agreed upon.
Okay.
Yeah.
All right. Thank you so much, Dr. Elizabeth, for joining us for this particular conversation. And of course, we'll welcome you back some other day so that we get to continue with this conversation.
Okay. Thank you.
All right, this is where we end this particular topic on the transition from NHIF to SHA. Right now, don't you go too far, because Mike Megwe will be back in a moment.